Good afternoon, everyone. I know it's lunchtime, so I'll just quickly go through my presentation. I am Dr. Rahul Gosavi, a consultant ENT surgeon from Miraz, and this is my place of work. It's a ENT super specialty hospital with 3 MS seats per year. This is our sister hospital, a comprehensive cancer hospital, Shri Siddhivinayak Ganpati Cancer Hospital. So my topic today is basically to discuss fungal sinusitis in the post-COVID era. So how do you define fungal sinusitis? It is basically the inflammation of the lining of mucosa of the paranasal sinuses due to a fungal infection. Classically, it was classified as clinical into acute and chronic, and histopathologically into invasive and non-invasive. The different types classically mentioned are the allergic fungal, mycetoma, fungal ball, chronic indolent, and then you have your acute invasive and fulminant fungal sinusitis. However, after we saw a huge epidemic of mucormycosis following COVID-19, the aim of this presentation is to make the clinician aware of differentiating mucormycosis and non-mucormycosis type of fungal sinusitis. So I am proposing slightly a different classification where, to simplify matters, either fungal sinusitis to be classified either as a mucormycosis type or a non-mucormycosis type. So non-mucormycosis type, as I have already mentioned, are the most common one is the allergic fungal rhinosinusitis. Usually it is a type 1 sensitivity IgE mediated hypersensitivity reaction, usually associated with nasal polyps. Characteristic CT scan shows the double density sign and has allergic mucin. There are different diagnostic criteria, however I'll rush through. So basically, allergic mucin having eosinophilic aggregate and Charcot-Leyden crystals is the hallmark of AFRS, as we all know. And this is how it looks while you're operating. It is a thickish secretions which are not very easy to remove by suction. You may have to give multiple washes. And if you encounter any of this, you have to remove it completely for complete clearance of the disease. On CT scan, usually it can be unilateral. Usually unilateral can be bilateral, and the classical sign is a double density or salt and pepper appearance, or the rail track sign as we call. The treatment of choice is only surgery, and I think these patients bleed slightly more than your routine chronic sinusitis patients, because this is infection associated with an allergic reaction as well. So you have to be very slow and meticulous while clearing out the sinuses. As you see, the anterior wall of maxilla here completely cleared, and then this is the fungal debris coming out from the sphenoid sinus, and you give multiple washes, and once you are done with your complete clearance of the disease, you will achieve such a nice cavity which will epithelialize in due course of time. This patient had a bilateral disease, so similar procedure was repeated on the right hand side as well. I will show you the right, yeah, this is after clearance, and as I said, complete clearance will give you a good picture, and patient will have satisfactory results after your surgery. Next up is a fungal ball. Basically, it is also called as mycetoma, and most common organism again is Aspergillus. This is how a fungal ball looks after removal. It is slightly crusty, hard in appearance, and again, I think the characteristic sign, again the salt and pepper sign can be seen in a fungal ball as well. Usually it is seen in the maxillary sinus, and usually it's a single sinus disease. Sometimes in the frontal sinus also you can see it. Sometimes there can be a mixed infection fungal ball. This patient had an Aspergillus with Candidiasis fungal ball. I think Candida was a super added on the Aspergillus, but again, as I already suggested, giving good washes, in 2 or 3 washes, the entire thing comes out, and this is how it looks. Sometimes there can be an AFRS associated with a fungal ball. I'm going fast with the video. So this patient had a fungal ball associated with type 1 hypersensitivity, and again, complete clearance. For complete clearance, multiple warm saline washes were given, and as you see, there are a lot of sticky secretions which you see in AFRS because of the eosinophilic mucin. So again, complete clearance is the only option here, because sometimes in a nasal polyps case, you may keep a 1 or 2 polyps if they are not easily resectable, because medical management will take care. But I don't think this is the option in a fungal sinusitis case. So this is after, I'll just rush through with the video a little bit. Yeah, so after multiple washes, as you can see, the entire thing is coming out slowly and slowly, and then you get a good cavity which will epithelialize in due course of time. So basic management of a non-mucor type fungal sinusitis is surgery, unlike chronic rhinosinusitis where you can try medical management, and gold standard is meticulous surgery with complete clearance. Medical management may include voriconazole, itraconazole, or fluconazole and steroids to complement. Now coming to the elephant in the room, which is the mucormycosis. So initially described in 1885, however, in the last few decades, it had become so extinct that a lot of the companies had stopped producing amphotericin B, and they had to run helter-skelter after the number of cases we saw following COVID-19 to produce or manufacture amphotericin B. Usually seen in immunocompromised states. However, during COVID-19, I think there was this theory that COVID-19 itself is suppressing the immunity of the patients, and along with rampant use of steroids leading to uncontrolled sugar levels. It was also seen in a lot of patients who had no previous any immunocompromised states as well. So clinical presentations, I think you all are well aware of. However, the first thing you see is the atrophic nasal mucosa or avascular field, and the crusting seen at the lower aspect of the middle turbinate or the posterior aspect of the inferior turbinate. And also you may encounter such things. So if you look at the picture, there may be eye involvement, palatal involvement or bogging, necrosis causing fistula, partial or total ophthalmoplegia due to cavernous sinus thrombosis. There can be multiple organ involvements, and basic aim is just to, if you see any of these pictures, the first thing now the young clinician should be aware of that this can be a mucormycosis, and you should think in that way, and that is the aim of my lecture today. So diagnostic procedures, DNA is the most common, and I think while doing an endoscopy, you should always take some culture for KOH, some tissue for KOH mount. So this is the early picture. This patient, if you see in this, there are no actual signs. However, this patient had a mucormycosis and or a partial ophthalmoplegia. So what you picked up is the atrophied nature of the turbinate and the avascularity seen surrounding it. So this is one or two pictures I'm showing. Then the other one is the other gold standard investigative technique is MRI, where sometimes there may the infection can spread intracranially or intraorbitally, and T2 fat suppressed MRI is the gold standard. Again, as I said, always take tissue while doing a diagnostic endoscopy and send for KOH mount, because it gives you results in 4 to 6 hours. So you can start amphotericin immediately and then plan your surgery accordingly. I think this is the most this is the most important slide in my presentation. You need a multidisciplinary approach. So basically, for any routine non-invasive fungal sinusitis, a single ENT surgeon, I think, is capable of managing it. However, if you encounter such cases, I will recommend everyone that you should do it in a multi-speciality setup with ICU backup. ENT surgeon, of course, should take the lead and be the captain of the ship. However, you will need help from your colleagues as well. So treatment protocol, antifungals, amphotericin B, I won't elaborate on liposomal. Cresemba or isovuconazole showed great results, and posaconazole is used for maintenance therapy. The role of surgery is basically debridement, removal of devitalized tissue and debulking of infected tissue, theoretically to allow for faster action of antifungals against a small burden of fungi, and of course to establish your diagnosis. So you may have to do multiple procedures along with a full house FES, like a median orbitotomy or orbital decompression. At the same time, a partial or total maxillectomy, medial maxillectomy, you may have to do a modified Denkers, and sometimes you may have to do palatectomy and repair the palate as well. Another thing I'd like to stress is always remove the middle turbinate in these cases for douching and complete removal of the disease. Post-operative care, nasal douching is absolutely paramount, and you always check for ESR, your CRP levels and serum electrolytes as well. And follow up, then you can send the patient for rehab after he's 3 months without any disease. So one case I like to discuss in particular, we operated almost 117 cases.
Time, sir.
20 seconds, sir. So he was a truck driver, very badly managed, and unfortunately we had to do exentration of the right eye. And left eye, we just picked it up in time and managed it. And right now he is again successfully pursuing his career, and he is very happy. So the take-home message is, after COVID-19, the clinician should have increased awareness of mucormycosis. Endoscopy and CT are the gold standards. However, the clinician should have slightly low threshold for initiating amphotericin B. 1 or 2 extra doses doesn't cause any problem, I feel. It is important to differentiate aggressive and non-aggressive disease. And the older concept that fulminant mucormycosis only happens in immunocompromised is slightly outdated, I feel. And a multidisciplinary approach is paramount. With this, I'll take your leave. Thank you.
Thank you.